Hello. Good morning, everybody. Our speaker today is Dr. William Poe. He'll be speaking on ACGME resident fatigue guidelines. Our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. William Poe grew up all over the world as a child of a military family, originally from Texas. He obtained his BS in neuroscience from Texas Christian University in Fort Worth and his medical degree from the University of Texas Medical Branch in Galveston. Dr. Poe was awarded a U.S. Air Force scholarship for his medical education and subsequently did his obstetrics and gynecology residency at the David Grant Hospital at the Travis Air Force Base in California. As an active duty U.S. Air Force OBGYN physician, Dr. Poe served at the 39th Medical Group and Incirlik Air Force Base, pardon my mispronunciation, in Turkey, 48th Medical Group, RAF Lakenheath, and the 31st Medical Group at the Aviano Air Force Base, Italy, often as the Medical Director and Chief of OBGYN Services. Dr. Poe left as the Lieutenant Colonel in 2002 to join a small group of OBGYN practice in Dallas. However, after several years, he was recruited and accepted as Assistant Professor at an ACGME OBGYN residency program at Wright State University in Dayton, Ohio. As an Associate Program Director, he quickly learned to love academic teaching and resident administration. Desiring to get a little closer to Texas, Dr. Poe accepted a position here at Oklahoma State in 2008 and is currently the clinical professor in the Department of OBGYN. He has been active in numerous positions, including a past member of the OSU CHS Faculty Senate and previous chair of the OBGYN Department at OSU Medical Center. He's a National Oral Board Examiner for the American Board of Obstetrics and Gynecology, and one of his most recent prized awards, the 2014 Attending of the Year at OSU Medical Center. Please help me welcome Dr. Poe.
Okay, first of all, let me just apologize. My little graphic is supposed to be ongoing here. Excuse me. Okay, so what we're going to talk about today is the ACGME fatigue guidelines. And the question is, how did this come about? So I'm going to go into this because I found this really kind of fascinating. Libby Zion. Libby Zion is the name that will go down into medical history. She was a college freshman with an ongoing history of depression, who came to New York Hospital in Manhattan on the evening of the 4th of October, 1984. She came in with fever, agitation, kind of a strange, jerky motions of her body. She also seemed disoriented at times. Unable to diagnose her condition definitively, the emergency room physicians admitted her for hydration and observation. As the physician of record, Raymond Sherman, a senior clinician who had treated several members of the Zion family, approved the decision by phone. He's like a family doctor. All right, there you go. On the hospital ward where she was sent, Libby was evaluated by two residents. One was an intern, about 8 months out from medical school, and a resident who had one additional year of training. So they too were not quite sure about what was going on with Libby. The resident termed it a viral syndrome with hysterical symptoms. Demerol was administered to control her shaking, and then Dr. Sherman over the phone approved that plan. Things get kind of shaky after that. So the events kind of have conflicting accounts. About 3 in the morning, the intern went off to care for 40 other people on their list. And then the resident went to sleep in a nearby building where he would be available if necessary by beeper. After the doctors left, Libby became more agitated. The nurses contacted the intern at least twice. The intern ordered physical restraints to hold the patient down to prevent her from hurting herself and prescribed an injection of haloperidol, another medication aimed at calming her down. Busy with other patients, the intern never evaluated the patient. This is all by phone. Libby finally fell asleep according to the nurses, but when the nurses ate took her temperature at 6:30 in the morning, it was 107 degrees. The intern was called and emergency measures were tried to lower the temperature, but she unfortunately suffered cardiac arrest and died. The intern called her parents telling them that the doctors had done everything they could. So to the hospitals, to the doctors, the case was called an inexplicable bad outcome in which a healthy young woman had died of some kind of mysterious illness or infection. So this 18-year-old woman died within 24 hours of an emergency room hospital administration in 1984. Her father, Sidney, was a lawyer and a columnist for the New York Daily News. He, understandably, was very upset, but started to really dig in and to investigate. Apparently, Libby was on an antidepressant known to cause fatal interactions and high fevers with Demerol. The residents were working 36-hour shifts. The intern never woke the resident or the family doctor, and Dr. Sherman was never called when the patient worsened. So, in some of the news articles I read, Libby Zion was quoted as saying, they gave her a drug that was designed to kill her, then ignored her except to tie her down like a dog. And then he began to refer to his daughter's death as a murder. And basically, he splashes everywhere and anywhere he could. This was on 60 Minutes, on the news. He tried to publicize this as much as he could. So in the winter of 1994, the case, Zion versus New York Hospital, finally went to court. Court TV covered the proceedings. There was a lot on both sides of vitriol. And then presenting the case, the hospital introduced a claim which was totally unsupported by toxicology and by vigorously disputed by the plaintiffs that Libby Zion had died of a result of a cocaine ingestion that she had concealed from her doctors. The jury hedged and attributed responsibility to both the doctors and the patient, and the Zion family was awarded only about $375,000. So basically, that kind of just the case itself. So it took a long time for it to get to court, but as the case was publicized, especially in May of 1986, the Manhattan District Attorney agreed to let a grand jury consider murder charges. They kind of declined to indict, but the jury issued a report strongly criticizing the supervision of interns and junior residents at a hospital in New York County. So in response, New York State Health Commissioner David Axelrod established a Blue Ribbon panel of experts headed by Dr. Bell. So a couple years later, in 1989, the New York State adopted the Bell Commission's recommendations that the residents could not work more than 80 hours a week or more than 24 consecutive hours, and that senior residents need to be physically present in the hospital at all times. The hospital also then started to institute a night float system. However, there are many institutions that just kind of ignored these regulations. So early in the 20th century, again, this is a little bit of a flashback just in general. Residents are called residents because they used to live in the hospital. You resided in the hospital. Residents frequently work more than 90 hours per week, and each week comprised 36-hour shifts, every by 12 hours or less of rest. So, I mean, I trained kind of in this manner. I would be on call for 48 hours. I would be in the hospital for 48 hours. And then maybe 12 hours off and then back on. So and for me, I trained this way for the 4 years of Joanne residency. So anyway, so when you think about it, there's an incredible amount of work that residents do. I mean, it's a labor force. So when you cut back on the hours that the residents do, there's a cost. Hospitals have to hire other physicians or more residents, or try to find more residents. They need more bodies to do the same amount of work. So back then, right after these hours were enacted, in New York alone, it was estimated that it cost $250 million to New York hospitals. And that they weren't really sure whether this actually improved patient safety or not. So despite the cost of duty hour restrictions and their failure to really clearly enhance patient safety, consumer and congressional pressure for national regulations mounted, and in 2003, the ACGME adopted a national standard for limiting duty hours, again, including the limitation to 80 hours per week, hours for a 4-week period, 1 day off and 7, maximal shift of 24 hours and 6 additional hours of education and handoffs. So basically, ACGME made it mandatory nationally for these hours to be enacted. Their decision was prompted by 3 different factors. Basically, a perception that healthcare delivery was becoming more complex and acute, and that there definitely was research at the time that said that sleep deprivation adversely affected job performance, and that public attention to, and that there was a great deal of public attention to resident work hours. I mean, it probably was the last part, honestly. I mean, they describe, I don't know whether you guys remember, 60 Minutes was this news show hour, that they would have people that would be interviewed. They actually had a resident on TV being interviewed, and he was so tired that he actually forgot some of the questions. So that really didn't make our medical education look very nice. And then in 2008, the Institute of Medicine released a report on resident duty hours recommending even stricter standards, again, including limiting internships to 16 hours and counting moonlighting hours as part of that. Then in 2011, ACGME implemented these changes as well. But they did admit, as ACGME did admit, that both the Institute of Medicine report and their task force, they found a relatively lack of scientific evidence in many areas of importance for setting standards to promote basically sound education and safe and effective patient care. So, basically, is it really safer? Basically, out there is evidence that sleep deprivation impairs residents' performance in controlled experiments. I mean, for the people with some gray hair, we had classmates, we had residents, colleagues, and we would have these stories all the time where they would fall asleep behind the wheel. Hopefully none of them, not a lot of them had accidents, but it had gotten, we knew from personal experience that this is a very real possibility. There was a day when I drove home, thank goodness, I parked the car in the driveway, but my windows were up, and the engine was on, but I had it in park, and I fell asleep. So basically, I woke up when my daughter and my wife were banging on the door trying to get me to wake up. But I have friends who were in car accidents. Thank goodness none of them were serious or kind of physically hurt. But stories like that were there all the time, and there was very much scientific evidence that with our profession and other professions, that sleep is a big issue. And the big area, of course, was the airline industry with pilots. Sleep is very much of a concern because they want their people to be sharp and alert. So, but yet, even though we know that sleep deprivation can be a big problem, we do know, especially in the evolving world of resident education, there are a lot of things that can mitigate that. Basically, team care approach with many programs where we may have members of the team who are more rested than others. We have EMR now with a lot of embedded decision support, like checking for drug interactions, the use of crew resource management and checklists. And the classic one with that is patient handoff. So that's why patient handoffs are really a big focus on ACGME. And then I think I mentioned before that there was a study in New York that in the 2 years after the original ACGME guidelines, they didn't really find any change of mortality. But they did find some increased risk of complications, and they attributed that to the fragmentation of care. So, and so that's the thing, is we want our residents to be well trained. To do that, you need continuity of your cases. In OB, we have our residency patients in the clinic throughout their prenatal course. But then when it's time for them to deliver, sometimes they're able to make that delivery because of our scheduling and our work hour requirements. A lot of times they don't. But that's a big part of this continuity in our specialty. The same thing with surgery. You work a patient up, bring them to surgery, and oh, by the way, you have to leave because you've met your work hours. So they clarify this as, it's unclear whether this has been a major problem in skills of trainees subject to 30-hour restriction, especially in so-called conflict fields. So with internal medicine, psychiatry, pediatric neurology, they make the case that, that those are specialties that may be less affected than others, like the procedural fields, like surgery, orthopedics, OBGYN. The literature there is really extensive, but really, all over the place. They seem to, in examining this question, there is a suggestion that a small but measurable negative effect on the surgical volume available to trainees was found, but there really were no studies that addressed whether graduating residents were better trained than they were a decade ago. So there's a paper, and I apologize because the logo was supposed to be there, it didn't really come out. But it has to do with duty hour limits and patient care resident outcomes. Can high-quality studies offer insight into complex relationships? Written in 2003 and published in the Annual Review of Medicine. So the basic, they've tried to kind of handle this question and look into it more by looking at several different studies. And at that time, they came to a couple of different conclusions. This is just in summary. The literature on the effect of resident duty hours on quality and patient safety and resident professional development preparation for practice produced mixed findings following the implementation of duty hour limits. There's evidence of a positive effect on some outcomes, particularly in medical specialties, but a negative effect on some surgical specialties. So basically, they're just confirming that looking at all these studies, they're all over the place. These work hour limitations seem to hurt the procedural specialties a little bit more. It's not possible to unequivocally attribute changes in quality and safety of care to the duty hour limits. Studies suggest improvement or worsening of quality and safety indicators are related mainly to faculty supervision and the involvement in care or lack of thereof after the implementation of the limits. So one of the key factors in the Libby case was supervision by either a senior resident or an attending. And so now that there is under the ACGME rules, there's a mandatory supervisionary kind of role. You have to have someone there who's more senior. You have to have an attending. So it's possible that a lot of these improvements are from that. The limits appear to have no effect on operative volume in surgical specialties, according to that study. However, study factors may influence these findings, and operative volume may be an insufficient measure of operative experience. Loss of perioperative continuity and the limits may have a negative consequence for the resident's professional development and preparation for practice in the surgical specialty. So basically, again, if you're working up a patient, and a big part of your education is when you take that patient to surgery and fixing that issue, you are there firsthand to assess this patient before, during, and after this situation. They did note that the limits of the work hours have reduced burnout and improved resident mood. Yet few studies have assessed whether this in turn has a beneficial effect on the physician-patient relationship. And basically, our residents may be happier, but are they better doctors? So the last point was that the duty hour limits appear to have reduced the continuity of care and educational continuity for residents. These losses may have serious consequences for the quality of care and the professional development of physicians in surgical specialties that are not addressed by efforts to improve transitions of care. So then the latest thing, which came out just this February, and in New England Journal of Medicine is the National Cluster Randomized Trial of Duty Hour Flexibility and Surgical Training, or the FIRST trial. So this is really incredible because they took 117 general surgery residency programs across the United States. They randomly divided them up into the current standard, which is the ACGME work hours, versus a flexible system in which you could kind of adjust the length of the shifts and the time off between shifts. They all had to adhere to the average 80-hour hour per week rule and follow all the other ACGME requirements. But those hours could be tweaked. So basically, the outcomes, first of all, primary patient outcome, which was listed as death or serious complication. In the current standard, there wasn't any significant statistical significance because the current was 9.0 and then the flexible schedule was 9.1. Primary resident outcome, which this was dissatisfaction with the quality of education. Again, no statistical difference between the system and the flexible system. And then another primary resident outcome was overall well-being. And again, it was not quite statistically significant, but it was almost there. The things that were statistically significant was the secondary outcomes. One of the secondary resident outcomes was continuity of patient care, 10% versus 4.7%. They were actually found to be less dissatisfied. So care and under the point of continuity of patient care, taking care of your patient throughout the labor and delivery or throughout the surgery really is beneficial. I mean, it's a big part of what we do as doctors. Another secondary resident outcome was leaving in the middle of an operation. Again, these are general surgical programs. So very often they would try to push the limits and they would be in the OR and someone had to say, well, I'm sorry, but you got to leave because you've met your work hours. So again, statistical difference there. 13% reported they had to do that. Under the flexible time arrangement, only 7%. And then another secondary resident outcome was handing off of active patients. Basically, you're in the middle of this patient that may be really complex. You're doing this, you're doing that, and then again, oops, you got to go. You've met your hours. So 46 versus 32%. Again, less likely to hand off. And then the amount of time for rest. Now, this did show that the residents reported that there was less time to rest under the flexible time schedule, 14.9 versus 18.6%. So again, the study did show that the flexible duty hours appeared to be safe for patient care, appeared to improve education without differences in resident safety, but the policy did affect time for personal activities and certain aspects of well-being. So it is a balance. I mean, again, the balance is patient safety versus resident education and resident safety as well. Again, we don't want people getting into car accidents when they're too tired. And we want people to learn. So I'm going to go through our policy here. Go to medical center policy. The purpose is, again, symptoms of fatigue and or stress are normal and expected to occur periodically. With the resident fellow population, just as it would with any other professional setting, not unexpectedly, residents may occasion experience some effects of inadequate sleep and or stress. As an institution, the Oklahoma State University Medical Center Trust has adopted the following policy to address resident fellow fatigue and or stress. So every program, every residency program needs to have a policy, and that's mandatory now. And again, so you can see from the original Libby Zion case, it's the thing that really zeroed in that appeared to be having a difference was supervision, and then your duty hours. And when you get too stressed out, it needs to be a plan, and this is basically our plan. So this talks about how to recognize fatigue or stress, and we've all been there, but overall it can be inattentiveness to details, forgetfulness, mood swings, increased conflict with others, lack of attention, to proper attire or hygiene, problems multitasking, and basically your awareness is impaired. You kind of go back to your rote memory. So the official response is that if you have a resident demonstrating stress or fatigue, again, it could be in a patient care setting or a non-patient care setting. And so in patient care settings, patient safety, of course, is the primary thing. We also are concerned with your personal safety and well-being of the resident and fellow. So our policy states that an immediate proper response needs to be made. In a non-patient care setting, you can be a little more flexible, depending on the severity and the demeanor of the resident. And then these are pretty much general guidelines. So the attending, in the interest of the patient and resident safety, if there's a recognition that someone's showing excessive fatigue and stress, you need to think about immediate release of this individual for any further patient care responsibilities at the time of recognition. So basically, as attendings, we're looking at someone, and they're stumbling around, get them away from patients before they make a mistake. The attending clinician or supervising resident should privately discuss his or her opinion with the individual, try to find out the reason for the excessive fatigue and or stress, and estimate the time of rest that would be required to alleviate the situation. So this is a hard one. So it's like, you got to look at the person and say, okay, you look really tired. Do you either need to take a nap or do you need to go home? So the attending must attend in all circumstances without exception to notify the chief resident, program director, or department chair, depending on the ability to contact one of these individuals, of the decision to release the resident from further patient care responsibility. So basically, if I see someone having problems, and I say, well, you got to lay down or you got to go home, you got to inform someone. You have to inform their chain of command, their program director or the chair of the department. If excessive fatigue is the issue, the attending clinician must advise the individual to rest for a period that is adequate to relieve the fatigue before operating a motorized vehicle. So you can't just say, okay, you go home. This national standard dictates that if you're telling someone to go home, you then need to make sure that they are safe to go home, at least safe to drive. So again, that may mean that they may have to go and sleep for a bit and then go home, or find some other means, Uber home, find a friend. So now stress is a slightly different thing, but if stress is the issue, depending upon privately talking to the resident or fellow may take immediate action to alleviate the stress. If in the opinion of the attending individual stress has the potential to negatively affect patient safety, the attending must immediately release the patient or the resident or fellow from further patient care responsibilities at that time. In the event of a decision to release the resident from further patient care activities, again, notification of the program administrative personnel should include the chief or supervising resident, fellow on call, program director, or department chair, respectively. So you got to tell someone. So stress is included with this. So if a resident or fellow has been released from further immediate patient care because of excess fatigue and or stress, cannot appeal the decision to the responding attendant. So this is important because I'll talk to people, and hypothetically, if I say, well, you really are stressed out. I want you to take a break, go home, or go lay down and take a nap. So what this says is you can't just say no. I feel good. I'm doing good. I'll pull through. So if someone has asked you to do that, again, especially in regards to your safety and patient safety, there is a possible policy that says you have to follow that. So a resident or fellow has been released from patient care cannot resume patient care duties without permission of the program director or chair when applicable. So this is serious. It's not just go lay down, go back to work. There's some flexibility with that, but if it gets to that point where you're kind of being relieved of duty, then you need someone to look at the situation, like the program director, and judge if there's been a sufficient amount of time for your fatigue or stress to be improved. Well, the OSU Medical Center policy also includes allied healthcare personnel. So the nurses around you, the people who work in the hospital with you, can do this. That they can observe you for signs of fatigue or stress. Sorry, excuse me. And report that to your immediate supervisor, who then would be, to their immediate supervisor, who then will be responsible for reporting the observation to the respective program director. So basically, if you're so stressed out or you're so sleep deprived that that your nurses are saying, hey, you got to back off, they'd have an avenue to report this directly to the program director. So residents, fellows who perceive that they are manifesting excess fatigue or stress have the professional responsibility to immediately notify the attending clinician and chief resident program director without fear of reprisal. So basically, the residents themselves are supposed to have the ability and the confidence that they can say, man, I'm so stressed out. I can't do this surgery, or shouldn't be around patients because I'm not safe. Then they should be able to remove themselves from that, tell their attending without fear of reprisal. Resident fellows recognizing resident fatigue and or stress and fellow residents should report their observations and concerns immediately to the attending physician, the chief resident, if appropriate, and or the program director. So basically, we all need to be looking out for each other. The nursing staff around you, your fellow residents. So, if you see someone who's so stressed out and tired to the point that you're afraid they're going to hurt someone, for their sake, call attention to that so that they can get the proper rest. The program director themselves, following the removal of the resident or fellow from duty in association with the chief resident, if appropriate, determine the need for immediate adjustment and the duty assignments for remaining residents, fellows in the program. So is the schedule too tough? Is there something wrong with that? So we need to look at that. Subsequently, the program director reviewed the residents, fellows' call schedules, work hour, time reports, extended patient care responsibilities, any personal problems and stresses contributing this for the resident or fellow. So, we don't want this to happen again, so we want to look into it. Because this is starting to affect his job or her job, it's important to find out what that is. I've told many residents in the past, if you have a situation where you need to take a break, take a break. We want you on the job, 100%. And if you can do that, it's fine. If you can't, we'll work with you. We'll change your schedule. We'll make things a little bit better. We'll give you a break from here and there because we want you here 100%. The program director will notify the departmental chair and program director of the rotation in question to discuss the methods to reduce the resident fellow fatigue. So basically we're just saying, is this an individual schedule problem or is this a whole program schedule problem? And so and if we need to make changes in that, then the administration of that program should take steps to correct it. Excuse me. In matters of resident stress, the program director will meet with the resident fellow personally as soon as can be arranged. If counseling by the program director is judged to be insufficient, the program director would then refer the resident or fellow to the Oklahoma State University Employee Assistance Program by direct contact with the director of medical education. And this is, we've got some additional information about this. But this is, let me just go through the rest of this, and now we'll go through the new stuff. So, again, if the problem is recurrent or will not resolve in a timely manner, the program director will have the authority to release the resident indefinitely from patient care duties pending evaluation from an individual assigned on an EAP. And this would represent academic probation or dismissal, follow house staff policy as outlined in academic standards. So if it's really serious, then we have to go through the process that's outlined in the medical center policy. The program director will release the resident or fellow to resume patient care duties only after advisement from the EAP, and will be responsible for informing the resident fellow as the attending physician of the individual's current rotation. So, so this is not for everything. So, obviously, if there's issues that can be taken care of on the lower levels, that's fantastic. But as you can see, the more serious a problem this is, the more attention and the more we have to start getting into the policies and the procedures and to make sure we follow them step by step. So if the OSU employee assistance program feels a resident or fellow should undergo continuing counseling, the program director will be notified if she receives periodic updates from the EAP's representative. Excuse me. Extended periods of release from duty assignments that exceed requirements for the completion of the training must be made up to meet AOA training guidelines. So obviously, if you're out too long, you may have to make up some of that time. If the residents or fellows are observed to show signs of fatigue or stress in a non-patient care settings, the program director should follow the program director procedure outlined above. So, so we have this employee assistance program. Again, the Oklahoma State University Medical Center EAP provides confidential counseling, consultation, evaluation, and information to OSU Medical Center employees, family members, including residents and fellows, and they will provide up to 3 or 4% no cost. They have a phone number and an address there. But I want to go through the updated information that OSU residents and fellows have access to the behavioral health services 24/7 through the CompSci's guidance resources. Our OSU residents and fellows can call toll-free this number 24/7 to discuss concerns with professionals with master's degree in counseling, social work, and other related behavioral areas. Residents and fellows can also initiate contact between 8 a.m. and 6 p.m. Central Time with an intake clinician via an online chat feature access at a website. Referrals for face-to-face counseling can be provided. Services are free of charge for up to 10 sessions. Guidance resources online also provides information on a lot of different topics, including health and wellness, family relationships, personal finances, and more. And then the 2 ways to get access to your guidance resources benefits. Again, the website, you enter your web ID, which is this, then create your user ID and password. Or you can call it an 866 number. You would speak with a professional who will listen to your concern and guide you to the appropriate services you need. And remember that the website you do need to specify whether you're a medical student or a resident as you log in, because they need help. They need to identify the specific services used by the 2 different groups. And for more information. So Pete says thank you. All right, questions? And I think it's interesting because the older generation of doctors, again, grew up without any work-hour restrictions. Excuse me. And so we see that that there is an issue, and more evidence is mounting to show that because of all the other things we have, again, like I'm saying, the EMR and the check off, the handoff process, patient safety has really not been really affected too much. And residents may be feeling a little bit better about working because their work hours are less. and their education is maybe being marginalized, but there's still a lot of studies that need to be done. There in that study where they had the flexible time hours, the residents were actually, as far as when they were rating their jobs, they were happier because they were able to follow their patient throughout surgery. They were able to deliver their patient. They were able to go through, at least in the hospital setting, go through that whole process with the patients, and then adjust their time hours so they would make that up later. So I think that could be the future. The ACGME is also talking about how, and this really makes sense, how different specialties need different work hour guidelines. So it's different for each specialty. So that could be coming down the line. They're talking a lot about that a little bit more. And hopefully we'll see some flexibility here, especially since all this time has gone by. We have not seen, a huge improvement in patient safety, but yet we have this concern about the education y'all are getting. And it's funny because I talked to my residents, and it's like the attendings are working more than the residents. And in our program, we have, and in reality, we're notorious because babies can take 2 hours to deliver or 20 hours. And sometimes you have to be there for the whole 20 hours. Then you have a whole day of work the next day. So residency is just like this cocoon. And when they graduate and get into the real world, it's a little different. I'm not sure we're preparing them for that. So anyway, thank you very much. Oh, and we're a little